Today we're inviting Dr. Mark Kissler. He's an assistant professor at the University of Colorado, the Anschutz Medical Campus, where he specializes in hospital medicine and serves on the Academic Leadership Council for the Colorado Center for Bioethics and Humanities. And in addition, Mark is, in addition to his work and teaching, Mark is also engaged in scholarship on attention, health humanities, and systems improvement. He received the Master's in Narrative Medicine from Columbia, and his work on attention has been widely published, including the New England Journal of Medicine and Academic Medicine. So please join me in welcoming Dr. Mark Kissler for his talk on attention in medicine.
Great. Thanks so much. Can you hear me okay? All right. I'll see if I can get my slides up here. Great. Well, thanks so much, John and Michael, for the invitation. It's great to be here. It's great to be among a lot of friends and folks who have supported my intellectual development and clinical development. I'm really excited to speak with you later as well. I have a few acknowledgments just wanted to have up front. So these are folks who've been involved in, supported, collaborated, critiqued this work, or created a space for it, or the work that preceded it. So just wanted to express my gratitude there. Sam Porter is a close collaborator of mine here in Denver. He's a hospitalist and a systems improvement expert. And so the Substack is a recent co-project between the two of us, if you're interested later on in checking it out. I just got off service, and I was attending for a week on the medical oncology floor. I work as a hospitalist, and I staff the unit a few times a year. And the patients there are really medically complex. They're often very, very sick. And in addition to being very medically sick, they're undergoing big transitions in their lives, their relationships with their bodies, often their goals of care. And one patient was transferred in from another hospital for a subspecialty consultation. He was doing pretty well, actually. He was doing a lot better than a lot of the other patients on my service. But when I walked into the room, I felt something right away. He was laying flat on his back, staring up at the ceiling. His wife had brought the chair over from the room and was kind of hovering over him with a notebook in her lap. And after I sat down and introduced myself, she began to ask line by line, lab by lab, about each of the abnormal values, of which there were many that had resulted over the last 48 hours, almost without looking up. I was in a biomedical frame. I was in a bit of a rush. We'd been making complex diagnoses, juggling consultant recommendations, procedure requests, trying to get things done with interventional radiology before the weekend, secure chats coming in on my phone. And I started at first by answering her questions. This is the slightly elevated LDH. These are the low platelets. This is what we're doing for the positive blood cultures. But then my perception shifted. In her hands, I realized she was holding not just a list of labs, but also parts of the person who she loved. She was trying, with very little sleep and even less of a sense of long-term hope, to hold him together. I was moved by this. We'd done this to them, this work of disintegration that's part and parcel of so much of the technical practice of medicine. Only a certain form of attention could hold a space for both of them to be integrated again. I think I said something rather clumsily to try and name that dynamic, to move us a little bit towards looking at the big picture. And she looked up from the notebook. The tension softened a little bit in the room. I can't guarantee, and I don't think I'll ever know, if it had any sort of lasting impact. So much of the time, we're just stepping into the stream of someone else's life. But I like to think that it was integrating for both of them to be beheld. And regardless, it affected me. It was one of the million moments of formation and self-making that happen every day in the clinical domain. We often think of self-making in sort of an impoverished way. I went to college in Boulder, and at Baseline Road, there was a copy of a bronze statue called the Self-Made Man. I think this is around, in various places. So I apologize in advance for putting this image in your heads. But I think it says a point here. In addition to the somewhat egregious act of concretizing a cliche, right? And in doing that in sort of the epitome of 1992 era masculinity, it's really an image of willed, muscular, and what I would call monadic or non-relational self-reliance. I say this not to denigrate strength, and given a chisel, I'd probably opt for similar abdominals to this gentleman. But for the clinician, as for the true artist, self-making comes in a different guise. It's less about incarnating a particular set form, an image, or an idol of the ideal self, and instead about it entering into a deeper relationship with the world, one that requires a certain amount of attention. In the 1890s, Claude Monet produced a series of paintings of haystacks over and over and over again. He sat in the same place and looked at the same haystacks over days and seasons. And here we see a different kind of self-making, or at least the trace of self-making, one that I would say is far more impactful, meaningful, and truth-oriented than the muscular sort of monadic self-sufficiency. This is a type of intellectual and artistic formation that's charged with attention. It's attention to the textures, to the light, and to the world that's not of one's own making. Through it, a particular sort of vision develops. From the vision comes a language, and from the language, ability to articulate. The self becomes, and the self becomes an instrument of deeper perception, one that's iterative, communicative, and interdependent. I think it's exciting to be in a place and with a group of people who are committed to taking the art of medicine as seriously and as rigorously as we do at science. And I would argue that that kind of pursuit requires attention at its core. My mentor in the narrative medicine program, Rita Sharon, was a Henry James scholar, and she would often use this quote from The Wings of the Dove, in which one of the main characters, Millie Thiel, speaks of a physician who takes care of her. So crystal clean, the great oh yeah, so crystal clean, the great empty cup of attention that he set between them on the table. It was like an absolute possession, a new resource altogether, something done up in the softest silk and tucked away under the arm of memory. There's a tangible nature to attention in this quote. It's something so real, it's almost like a cup, something that can be tucked away and felt. Especially for those of us who work in the clinical work, it's useful to be grounded in the body and in the tangible. The words attention and distraction themselves encode physical sensations and metaphors. Distraction being a pulling away, attention a stretching toward an object or a subject. And when our attention is absorbed, we often feel it in our bodies. We have a profound unity with our bodies, like what psychologists call a state of flow, the fluid, precise application of expertise, right at the level below conscious awareness. It's a movement between thought and action, and back between action and thought, with little or nothing intervening, and it can be pleasurable, creative, even beautiful. And as we see in this quote, it's primarily, particularly for our patients, a gift. The French philosopher, social activist, and mystical thinker or religious thinker Simone Weil was one of the century's most important and original writers on attention. She's been a major interlocutor for me, and her writing kind of a mentor of sorts as I've been thinking about and trying to better characterize attention. Her work was interrupted by her death at the age of 34, and it consists mostly of essays, fragments of notebooks, and letters, which touch on the concept of attention in really diverse concepts, like labor practices, international politics, school studies, but most importantly, for our purposes, with the care of the suffering other. Her work doesn't culminate in a systematic philosophy, but rather her slow development of the concept of attention creates an experience in her reader through reprisal, repetition, and deepening, not unlike the hidden curriculum of medicine. The close reader of Vey comes to understand that attention is a fundamental disposition, at the root of what she sees as an authentic pursuit of the good. One of her most famous quotes comes from a letter that she wrote to a friend. She said, "Attention is the rarest and purest form of generosity." This wasn't written out of kind of a fluffy sense of sort of a sentimentality. She was writing to Joe Bousquet, who was a soldier in World War I, was paralyzed, and spent most of his life in tremendous pain. He became a poet, and he wrote afterwards, "A single bullet will take 32 years to kill me," of his experience in the war. This harrowing affliction and this encounter with affliction was really the place that this revelation for Vey came, of attention being a rare and pure form of generosity. This is often quoted without the two lines that follow it in the letter, but both of those also have something to do with our project. The next line she wrote is, "It is given to very few minds to notice that things and beings exist. The existence of others outside of the self, of real objects towards which we can be drawn, independent of our abstractions and the concepts that we place on them, is key to Vey's concept of true attention." And finally, she wrote, "Since my childhood, I've not wanted anything else but to receive the complete revelation of this before dying." And I think in this third sentence, we have both the aspirational nature of the call to attention. Not even a thinker as great as Simone Weil felt like she had received the full revelation. And it really was a revelation. It wasn't something that was worked out, but something that was granted, this full understanding of the nature of attention. And also we see it's immediately proximate to mortality, to the concept of suffering and death. In this characteristically uncompromising voice, Vey walks us through right into the gift and the difficulty and the stakes of true attention. It's easy to make the case that our attention is massively fragmented in contemporary medicine. The degree of multitasking, parallel processing, complexity of the information we manage, not to mention all the different modes of communication and documentation, they create environments that are often not built at the scale of clinicians or patients. Even well-intentioned quality improvement efforts often further tax the attention of clinicians, thinking of best practice advisories that pop up, additional screens, metrics, benchmarks. Sometimes it feels that our attention is the only remaining glue that holds together the various pieces of the industrial medical apparatus. Attention is not only a metaphysical phenomenon, it's a neurocognitive one as well. And there's a growing body of literature on cognitive load and related concepts that's relevant to these concerns. Some of my more recent work has been about not how to encode these philosophical ideas of attention within health systems, but rather to articulate them in ways that are coherent to stakeholders so that systems might get out of our way a little bit, become less cumbersome, become less interruptive, and to allow for those moments in which the interpersonal can emerge. Because it's not enough for the pursuit of attention to be a personal endeavor alone, us against the world, but for us to be enmeshed in communities of shared practice. And as we work together in shared practice, to work to articulate these as institutional priorities, because it contributes to quality care and to the meaning of our work. The focus on attention is not looking away from the technical aspects of care or the requirement of technical excellence, just the opposite. The same attention pertains to both. In her essay, Notes for the Right Use of School Studies with a View to the Love of God, Vey writes, "The development of the faculty of attention forms the real object and almost the sole interest of studies. Beyond the acquisition of discrete facts, education is concerned with the development of a certain kind of thinker, one who can be seized by knowledge and drawn out of oneself. I think of it a little bit as the difference between a clinician who can easily pass a multiple choice test, but has a lot of trouble in the clinic, and another who is on the road to discerning the wholeness of clinical situations, perceiving subtle changes in status, in all the messiness and noise and contingency of the world. For Vey, the important part of study is that it allows a person to move through that initial state and into the latter, to attend, yes, to facts, and also to relationships between facts and relationships between facts and persons. In the space of encounter enabled by attention, we risk our own unmaking. This is a dangerous space to step into. I remember before my formal clinical training, I was shadowing a palliative care physician at New York Presbyterian. And one week we went to visit a patient with fulminant liver failure. I didn't have any clinical experience before this. I had very little concept of the physiology of the liver, and even less of a concept of what a phenomenologically naked experience that was. I didn't have terms for what I saw. The jaundice that was so intense that it seemed to bleed out onto the bed sheets, the ascites, the fetor hepaticus, bruising, how quickly we tame all these things with abstractions and classifications. And we're taught in our training to move quickly, to control an intervention and away from something that fills us with awe, even if it is awful. It's not of our own making. It's not wrong, and I'd say it's essential. I often emphasize this with my medical students that they must learn to classify and abstract, to break problems into their constituent parts, to disintegrate for the sake of intervention productively. But it's not the whole story. By cultivating attention, these experiences of unselfing form a basis not only of our intellectual but our moral lives. In clinical medicine, many of the catalysts for encountering reality come together. The beauty and the fragility of the body, the hardness of affliction, the intellectual rigor of the practice, and the ethical nature of the call. Training, when undergone in a proper frame, might forge clinicians towards greater perceptivity, sensitivity, and attention. And this is often not led purely by effortful will, but by desire and authentic curiosity. They wrote, willpower, the kind that if need be makes us set our teeth and endure suffering, has practically no place in study. The intelligence can only be led by desire. The intelligence only grows and bears fruit and joy. This developing, iterative, slow reception of the revelation of the real is, for Vey, the fundamental ethical posture. The ethical person tries to encounter what is, avoids the less than real abstractions and projections that can be substituted for the difficult and harrowing encounter. The wound, as has been said, opens in two directions. It touches those who touch it. And it resonates sometimes through history in the archetype of the wounded healer, or in the reality and the immediate presence of wounds that each of us encounter and then carry with us. They wrote that absolutely unmixed attention is prayer. And I love this in the sense that it brings us to such a proximity with the infinite as we encounter within the other, and for those of us within faith traditions for whom serving the suffering other is also a way of encountering a real presence of God. There's something encoded in that statement too. Absolutely unmixed attention is prayer. So I'd like, as we get close to our half-hour mark, I'd like to close with a thought that risks unsaying some of what's already been said. We've spoken a lot about clearing the ground for attention and cultivating the capacity for attention, for guarding and stewarding attention as a resource. It's a major object of our study and our clinical practice. But I would like to propose that after all of that, it's also in our willingness and the availability that allows our attention to be diverted, the real care actually happens. I recently heard a gloss of parts of sayings of the Desert Fathers by a Bishop Eric Varden. He recounted this story from Sayings of the Desert Fathers. He said, "It was revealed to Abba Antony, who was a hermit in the desert, that there was one who was his equal in the city. He was a doctor by profession, and whatever he had beyond his means, he gave to the poor, and every day he sang the Sanctus with the angels." Here we have the image of the desert hermit, who is the prime image of uninterrupted attention, who spent his whole life cultivating a formidable, almost superhuman, or at least as perfectly human form of attention as we can imagine, juxtaposed with the city doctor, active, alive, above all, highly interrupted, and singing praise. The bodies of people press up on us, too. In the clinic, the ill among our friends and families, the displaced in our communities, our children asking for water in the middle of the night, patients or the patients of others who call out to us or make eye contact as we walk across the ward. In her essay, Forms of the Implicit Love of God, Vey wrote of the Good Samaritan that his gift was in his ability to turn aside from his task. The actions that follow, she says, are just the automatic effect of this moment of attention. Attention that is creative because it opens up a space of encounter. It's beyond our simple everyday capacity, but that's perhaps the point. Throughout Vey's work, she invites us to this interface between the finite and the infinite, between the act and its inspiration, seeking the good not beyond experience, but right in the middle of it, inside of it, in the in-between or the meanwhile of the world. Vey seems to affirm that the ethical call that we encounter in our clinical work to engage and relieve suffering, to achieve excellence of technique, to reform the systems in which we practice, the ethical call to do those things will always exceed our ability to do them perfectly. But that stepping into that gap is the difficult and uncertain work of a good life. So I'd like to transition now. I think we have a little bit of time for conversation, which is the part I'm most looking forward to. So thanks.
I think John had asked me just to say a few words, and then John will open up to conversation.
Great.
Thank you, Mark. I appreciate you putting this important subject matter on the table and leaving us time to talk about it. When you talked about flow and focus, attention, and I was thinking about personally the experience in the palliative care clinic in recent months of having someone, a veteran, come in with a loved one in a state of kind of agitation, of frustration. They've not been getting what they expected or hoped, and they're almost, you can tell, anticipating this is someone I'm meeting for the first time. This is going to be more disappointing. And the gift of just kind of putting everything aside and being able to say, tell me what's going on. You know, tell me what, tell me what's going on. To give them my attention. And it strikes me that that experience of being able to give attention, whether it's in that kind of a context or when someone is genuinely sick and it's sort of drawing all of our focused energy to try to figure out how we can serve them well so their sickness is abated, their health is restored, you know, is what makes us come alive. And it's the work that is makes medicine its own reward. Um, and so I guess I'd love to hear you talk a little bit about attention as you see it, and it is not to have you agree with me, but to what extent is attention the secret of keeping alive the love of medicine? Um, Second thing is HippSoc, I think, aspires to form its participants, for us to form each other and form ourselves in the capacity to pay attention to what we're doing in medicine and not take for granted the systems and operations that we inhabit, not take for granted our own patterns of life, but try to really turn attention on ourselves, uh, so that we might better attend to those we care for. And I'd love to hear your thoughts on how we can do that well. Um, and then I'm thinking about C.S. Lewis in his book, in his Screw Tape Letters. There's this passage, and I can't quote it verbatim, but this is passage where where the devil, the senior devil, writes to the younger devil and says, it's really critical to keep humans thinking about the future and thinking about the past. Thinking about the future because, and he said that's where most of the money is, because that's the easiest to do. We can be anxious about what might happen in the future, but the future doesn't really belong to anyone. And in the past, similarly, all you really have is it's the present that touches eternity. And I'm just kind of curious your thoughts about how this notion of attention relates to the idea of being present one day at a time to the now. Um, and with that, I'll turn it back to you and John.
Thanks. Um, well, I can, I guess, speak to a few of those or just start and then maybe some more texture will come out, as we continue. But as I hear, there's kind of three things that we're looking towards. One is the degree to which attention might help to foster the love of medicine, the way that it kind of helps foster the goodness that we encounter as clinicians. The second being, what are ways that, as part of kind of the Hippocratic Society, some concrete ways that we might cultivate both attention, but also just this approach towards individual practice and sort of system engagement and a broader vision for our work. And then the third is attention as presence. Is that a good gloss of? Okay, they're great. I really appreciate those questions. I mean, I think for me, part of the beauty um, of focusing on attention. I think that sometimes one of the places that our fatigue and sense of being kind of set upon by our work comes from is in its generality. It's very uncommon that I feel that out of the specificity of an individual interaction. That there's something about that live spark, I think, that's I don't know, it's fascinating. And it brings up things that are, even if it's difficult, it can bring up emotions of interest and curiosity and desire to follow a path, to know a little bit more. Um, I you know I find myself trying to pay attention to the questions that come up when I'm working with a patient because I'm genuinely curious, things I really want to know. I love to. I took care of a gentleman who's recently. He said he was recently retired from his work as a doctor, and he was in his late 80s. He had practiced for a really long time, and the curiosity that arose in me was, well, what is tell me about that. Tell me about who you are. And that you could then set down that work with he seemed to set it down with a certain amount of joy too, not relief, not a sense of being unburdened, but just of being grateful for what it had been. And that's, I mean, what a cool thing to be able to go to work and do that, have that kind of conversation. It's not always that way. I think that I also encourage my students sometimes to be attentive to the negative emotions or the frustrations that arise or the things that are the frictions that you feel with patients. Because even those negative emotions, there's something about that's very real. Um, and I think it's when we're kind of in mesh, like really, really engaged in that specificity and that reality. It's hard to imagine being bored of that component of it. And what I find myself feeling is less a desire to escape that and escape that work, and more a strong desire, often to remove any barriers that present themselves to doing that work. And so sort of focusing that energy on those barriers instead. But that's just a thought. That's kind of a more personal answer to the general question. But I think one of the things that I'm curious about, and I think I really believe in, is that beauty can prepare us for engaging suffering. So I'm moving into the second question, that the one of the ways that perhaps, and I think you're already doing this, with the Hippocratic Society, is sharing meals together, looking at art together, reading poetry together. That those things are not that not only are they not frivolous, but those are actually the ways that we prepare for the difficulty of the work. And for the difficulty that it takes to engage health systems that are not necessarily built to prioritize those things. I think that there's a real significant, palpable force that beauty exerts, and that the articulation of beauty and the celebration of beauty together. The joint attention. What my favorite, I trained in combined internal medicine and pediatrics, and one of my favorite phases of development is when children start to develop joint attention, where you start to see them point at things, and then rather than just looking at the thing, they look at their parent to see if their parent's looking at the thing that they're pointing at. It's such an incredibly beautiful human thing to bend our heads over the same object of interest or of beauty. And I think the more we can do that, the better. I can't think of a better type of formation than that. Um, and I think attention as presence, just kind of speaking to the third topic, I think absolutely. I think what I love about this idea of attention, is that I think it can be made to speak the language of RVUs, because we need to pay attention in the clinical environment to have accurate diagnoses, to do the things that the system, that the external goods care about, that we need to be able to be present and not too distracted to do those things. But it also speaks this totally different language of this other discourse of presence and kind of interpersonal awareness, and even of kind of a spiritual attentiveness and waiting. And it's that commerce between those two things, that I think is really powerful. And so the more that we can articulate kind of that, the good that we have to offer is so much in our ability to attend. It's not in our throughput. It's not in our, more and more, I think that patients say it, people understand it, we know it, deeply, that that's the good that we're doing in the system. And whether it's a good of an accurate diagnosis and an appropriate treatment plan and a very kind of biomedical good that's being done, or this good of witnessing or reframing or articulating something new. I just think that all of those belong to that same kind of both cognitive and in metaphysical, whether it's metaphysical or what, this excess, the overflowing of that moment of presence. So.
Thanks so much, Mark. And throughout the conversation, please also, for the rest of the people on the call, feel free to add questions in the chat box, and we'll go through them as well. And so just to kick off some of the questions, especially because of your interest in narrative medicine, can you talk a little bit more about the relationship between patients' stories, narrative, and attention?
Sure. I guess I like to think about, so one of the key concepts in the practice of narrative medicine is that illness unfolds often in stories, and that we learn a particular way of reading or listening to a story through our technical training. And that's one that's often about distilling, or kind of removing the facts out of the context. So we're listening to a patient tell the story, but what we're really listening for are the pieces of the review of systems that we can slot that into, and kind of salient, pertinent positives and negatives. And narrative medicine would propose that that's not wrong. That's part of the work, but it's really a partial way of listening. And how impoverished our reading would be if we read, Dostoevsky for the point or the moral, right? It's not about just that. It's about all these other things that occur and unfold within us in this kind of what you call an intersubjective space, right, between you and the work. And that the same skills of close reading that you can apply to a text might be applied to a clinical encounter. And I see that all the time. My patients speak in metaphors all the time. My patients will, through their diction, you see them walk up to a point and then recede from it. Or they'll walk up to a point and then instead of saying that thing, all of a sudden, they're using a different language. The language has been bald and, blunt up until a point, and then all of a sudden they're speaking very in vague terms. And those are ideally skills of listening and of reading that can be honed through things that are not always clinical, that we can learn to read books, that we can learn to read poetry, we can learn to engage with art, and that some of those skills translate over. Another key component, I think, is that we're often encountering people in a profound state of interruption. And so there's a large degree to which we think of our lives and we tell ourselves a story of what we're doing, where I've been, what I'm doing now in order to get where I plan to go. And illness, especially severe illness, but even, I was climbing a mountain with my buddies and I stubbed my toe profoundly on the top of the mountain. And even that kind of minor thing can create a really huge interruption in kind of what I expect to be, the next few weeks of soccer practices and, and things like that. And that not to trivialize it, but I think really a lot of the work and a lot of the work I do as a hospitalist is right in the middle of that interruption. And one of the things that can happen with a real profound interruption is that people can lose the plot. They have a sense that I used to know who I was and where I was going, and I don't anymore. Um, so I think in my practice of, or kind of juxtaposing narrative and medicine, is not that I'm there to reimpose a narrative on someone's interruption, but I'm there to bear witness to the fact that there is an interruption, and ideally sometimes to create a space for a little bit of reconstruction and reintegration and re-narration of finding the plot again. Um, so if that kind of answers the question.
Yeah, I'm going perhaps a little bit more into this idea, especially from the viewpoint of the patient, that when they come, this interruption of plot, this fragmenting of identity that sometimes illness brings about, I think also results in a fracturing of attention for the patient as well, because there are many anxieties that then surface, as well as many perhaps deeper seated um, questions, meaning of life. And then there's sometimes I find a scattering
Mm.
of patients' attention as well. Is there ways in which, as a physician, you can help actually attention cultivation in the patient themselves, and also how we may think about attention and the growth of attention in the patient too?
Mm. Yeah, I think it's tricky. I guess I try to have as much humility as possible about my ability to affect change. I do like I think we show up and we do our very best, and sometimes that is to create spaces for people to undergo what they're undergoing, and to do that not alone. And I think that I think that maybe sometimes all people need is a space of listening. That metaphor of the great empty cup that we, in order to reconstitute ourselves, just like if you have a hard day at work and you come back to the person you love and you tell them about it, that part of that is because you need a space of listening to reconstitute a sense of self. So I think we can provide that. But beyond that, and beyond sort of that provision and that space making, I think we tread very lightly in that and with a lot of humility.
One question that's come up in the chat by Gabriel is he asked if you could describe more about your encounter with the patient with liver failure and this idea of unselfing, and how you mentioned the experience was something beyond words, and what a lack of ability to describe had to do with perhaps that sense of unmaking of self.
That's a great question. Um, Hmm. Well, I think so. I think there's a couple things here. Um, I think we can be unmade by things even if we can talk about them. So I don't think it's necessarily um, that the inability to articulate something is necessary for that. I think rather it's sort of a sense that we one of the ways that we can avoid a direct or avoid an encounter with something that risks this sort of unmaking or unselfing is by naming it and categorizing it in a way that allows us to avoid direct encounter with it. If that makes sense. That I think there's a way that we can put concepts up in the way, and say, oh, that's another, this is another case of XYZ. And it's in that naming and categorization that we almost try and put things back into a box. And I don't know. We do that. I think we just do that a lot with a lot of our experience. If I can say, oh, it's that kind of person, or it's that kind of encounter, that kind of patient, that there's a certain perceived safety in that. It's not me. It doesn't implicate me. I don't have to attend to these uncomfortable things that come up as I come face to face with my own fragility and uh, in that encounter. So I think that's what I would think about. At least initially, it's a great question. I have to think about it even more, but that really it's the way that we use language to distance ourselves from that phenomenon that's at issue.
Mhm. One thing that you were mentioning that I wonder is also this idea when we were talking just about the tension of the patient being fractured, and whether there may be a role of the physician to also help consolidate and chart a path forward that then may also bring tension together.
Mm.
I guess what I mean more specifically about that is I feel like in my palliative care practice, when I can reflect back to the patient that at this time where life is shorter, that those things which universally tend to be relationships, which is like what patients find most meaningful, if you're able to help show them that like, okay, if this is like what's most meaningful, and this is how maybe then would be most meaningful in terms of living out this time you have in your life, that in some sense consolidates and brings together the attention for the patient to
Mhm.
then focus on, yeah, this is like what's most meaningful. You can
Mhm.
create that sense of road or light, or that bringing together for patients.
Yeah, that makes a lot of sense. It's such a gift. It can be such a gift to tell someone the truth, right? Um, and to be able to perceive it in a way that maybe they hadn't been able to perceive before. So yeah, absolutely. I think that really does a lot to charting a path forward.
One other question here that's come up. So Joe Bluefill is asking that in his practice, considering AI generated medical records, where a machine overhears the conversations and generates a progress note, this is becoming more common in a lot of places. And that this might enhance our ability to remain attentive, perhaps to the patient with things like eye contact or avoid distraction, and with the need to interact with the electronic health record. And he's wondering if you have experience with this or even this general role of scribes, all with this idea of trying to help the physician be more attentive.
Mhm.
And then mentioning that perhaps people have also been reluctant because having another person may feel their presence may seem intrusive or maybe emphasize a transactional environment in the encounter. And you had any reactions or thoughts about that?
Yeah, our practice, we're also under conversations of rolling out a similar kind of listening scribe device. And I don't know, I think it's so hard to say what any of these new technologies are going to mean and do. And I think that I'm really curious about ways that we can learn them, that people who are really invested in the interpersonal encounter can learn these tools. And learn them well so that we know how to help to direct them and use them as tools. Otherwise, our tools kind of escape from us and sort of create their own patterns of use. It'd be a lot better if we we're trying to drive the ship, I think, there. So I'm curious. I'm planning on experimenting with it and seeing if it will enable a different kind of attentiveness in the clinical encounter. I think also, though, yeah, I think it can only do so much. That at the end of the day, it will be a tool and probably heighten some of the bad tendencies that we already have, and hopefully address some of the bad tendencies and nudge them in the right direction. But it's hard to know. I think these tools are fascinating, but probably going to change a lot.
There's a question here from Christian. He asked, so one may posit that with greater attention to a patient and their experience and story, you enter into this deeper vulnerability or a deeper ability to be wounded by their suffering. And how do you balance seeking to receive a patient with greater attention while also maintaining the sense of where boundaries are with them and their experience?
Hmm. Yeah, I mean, I think I would love. I mean, I'd love to hear Christian reflect on that. I think probably everybody in the room has a relationship with this question because I think it's really core to our work. And I suspect, at least in my own practice, that there isn't really a space in which you're not touched by what you see. And for me, at least, turning towards that, yes, maybe can allow it to get deeper in a certain way, but it's not as if there's a space where it doesn't contact. And I think sometimes it's when we're trying to push it away that posture is actually one that creates more wounding or lodges that wounding in a deeper place. The other thing I think, I think boundaries are really very important and being clear about where those boundaries are, but also looking outside of medicine for the healing of the wounds that are sustained through the work has been important to me. That not expecting. I think that sometimes we hope for and want our patients to heal us of the wounds that they bring to us, and sometimes there's deep healing that can happen in patient interaction. But I think sometimes we just have to get that from other places, from other relationships, and outside of our work to go and be healed. So.
There's a question here from John. He asks, so do you see attention as a resource to be spent throughout the day or more of a skill to be cultivated? Perhaps is it equally both of those things?
Hmm. That's great. I mean, I think we're playing in metaphor there a little bit too, right? Is attention a resource? I think there's a very real sense that it is a limited resource at times. That there's a very real way that if I'm interrupted 3 times over the course of a clinical encounter, that's going to affect the quality of attention that I have. And so then I think arranging one's day and cognitive environment to the degree that you can and being protective of it, thinking of it as a resource can be helpful. But I think also it's a capacity, it's a skill. I think it's a habit in a certain sense. And so I think it's a little bit of both.
I think a lot of the things that you're mentioning, Mark, is reminiscent not only of what you're mentioning, but also what you talked about in terms of Simone by talking about attention seeming almost like contemplation or equivalent to like a contemplative gaze or a contemplative approach to one's life. Um, Both even the idea of um, having this like third thing that you were talking about with kids and joint attention, but also this almost mindful approach to the day. And yeah, could you talk about whether there's like then is there two types of attention? One that maybe one does have like a bucket that decreases over time versus the sense of attentiveness that is maybe more contemplative in nature.
Hmm. Um, I wish I was spiritually advanced enough to answer that question. I think that the sense is that this is something that you can deepen the well, right? And that you tap into sort of this contemplative sense it's not just about focus, right? It's not just about your ability to focus on something. There's something that overflows that a little bit. But I think that that's probably the work of a life, that's the work of a life to really engage in that question with sincerity.
Ethan just wrote a message. He said, curious, especially knowing about Vai's aesthetic background. What does she have to say about the key relevant virtues that support attention and vices that disintegrated?
So she, yeah, she has kind of an interesting trajectory with relationship to her asceticism. And she writes, she doesn't think about attention. I think it's important to remember that attention isn't included typically in a traditional list of the virtues, right? That it's not, attention is not counted as a virtue. It's something else. And what that is a little bit hard to pin down. She sees that willpower, we kind of talked about the ways that willpower doesn't have a significant place in this pursuit of attention, that it's more about kind of an asceticism of the senses and about the will and a lot of waiting, with the exception that she sees willpower in terms of avoiding those things that disintegrate or splinter our attention as being pretty important, kind of that removal of the self from those things. She doesn't talk in my reading. She does not take sort of this virtue-based frame. She's coming at it from a little bit of a different angle. And in none of the writing that I have read of her, kind of through all the essays and essays, does she approach it from kind of a virtue-centered frame. Um, it's much more this kind of intersubjective um, and really a kind of a discipline of waiting and of emptying the self that she comes at it from. She doesn't really, she's interesting because she comes from a very secular Jewish background. She doesn't engage necessarily until very late in her life with things like, Thomistic theology or things, where you would get, or some of that kind of the theological virtues. She did, though, have a great love for the Greeks, and for classical virtue in that sense. So maybe that would be a place. I have to think about that a little bit. Yeah, I don't think of it not so much of an enumeration of virtues, but about a virtuous life in kind of a classical sense. Seemed to be very important to her.
Yeah, I think related to that too, she has like an essay where she talks about the idea if you study geometry, even if you don't like geometry, that it actually cultivates the sense of attention, and that the highest part of your attention is that which reaches God. In the
Mhm.
sense that I think again this like idea of contemplative or contemplation and attention perhaps together, and also the idea that if you practice attention even in things that you might not love to do, that perhaps that's actually where you may grow the most in your attention because you're practicing it in those things that are hard to do. Which I think maybe brings us to, because we only have 2 minutes left, to the last question, which is in modern medicine, sometimes it feels like um, it's almost like made to fracture your attention. Like
Mhm.
you're like constantly checking your phone because you're like, maybe my resident is texting me, or the email because somehow emails have become sometimes urgent, sometimes not, sources of things that we have to pay attention to. And yeah, how can we reclaim attention in this environment? What are some things that perhaps you could leave us with in terms of practical things that we could reflect on to grow in attention in our practice as clinicians?
Yeah, that's great. Thinking about the ways that we can reclaim our attention is, yeah. I mean, I think all these things are really worthy questions. Maybe the first step is just foregrounding it as something that's worth talking about, and that there's a real legitimacy to saying, we need to foreground clinician attention, and our ability to be with patients, and then using different people's different expertise. And if you're a quality improvement person, or you're a workforce person, or you're a boss of a bunch of a clinic, and I think there's a lot of different ways that can be brought to bear. But maybe just articulating its importance is kind of the first step.
Great. We're right at time. So, Mark, thanks so much for joining us, and Bar for being our discussant, and for everybody else who's joined on the call. Thank you so much. And yeah, our next meeting will be our working group meeting. So please remember to sign up. And also happy to continue to interface with people. Also, if you have additional things that you want to ask or talk to Dr. Kissler about, I'm sure he'd also be happy to connect with you. But
Yeah,
great.
absolutely.
Thank you and have a good evening.
Thanks so much. This is really fun. It's great to see you all.
Thank you, Mark.
What's up, brother? Yeah, I think you're muted.
Yeah, I was thinking we were gonna do some announcements, but guess we're good.
Yeah, no, I thought so too, but then the timer now, and I thought it was all right.
I had the
Um,
working group sign up all copied and pasted in the chat. So ready.
uh, um, yeah, I don't know what happened with the links. Apparently, there was a problem with the links.
I had a little bit of a problem. I had to make myself a Zoom account real quick.
Yeah, what on earth?
So
I've never seen that.
because my old one from TAC wasn't working.
Hmm.
Um, yeah, it didn't cause too much extra hassle for me, but it was kind of weird. Yeah.
It's frustrating. And then also, I think somehow there's two links because I set this one up for this meeting, but then some people joined my personal meeting link, which I put
Uh,
somewhere. I think I put on the calendar or something.
I
Uh,
wonder if we got less than half the people that actually signed up.
yeah,
I wonder if the link confusion was why.
yeah.
Maybe.
I hope that's why. Yeah. Well, yeah.
Yeah.
Slightly
So that was
disappointing.
great. That was a really good talk.
Yeah,
And
and we got it
pretty
recorded.
decent turnout. We had 32